Hi everyone, I am Dr. Anbumuri, Professor of Pathology. Today we are going to talk about the pathology of cellular adaptations part 3. The cellular adaptation topic is one of the basic major topic to understand the most of the other topics. So this is the competency of 2.6 which tells about discuss and describe the cellular adaptations. So the objectives will be what are cellular adaptations, the types of cellular adaptations with an examples and mechanism in detail. So cellular adaptations. Cellular adaptations are reversible change in the cell in size, number, phenotype, metabolic activity, and its function in response to the environment. So this is a picture which depicts about the adaptations. Normal cell, the types are atrophy, hypertrophy, hyperplasia. The other two adaptations are metaplasia and dysplasia, which there is no phenotypic change in the first three, but the other two has the major phenotypic change. So the first one in detail is atrophy. So the atrophy is a reduction of the number and size of parenchymal cell. The atrophy is again divided into physiological conditions of atrophy and pathological conditions of atrophy. In physiological conditions, it is atrophy of the lymphoid tissue in lymph nodes, appendix, and thymus. So, the atrophy of gonads after menopause or atrophy of the brain with aging. The best example for atrophy during the early developmental stages will be thyroglossal cyst and umbilical vessel degeneration. In the later life, the breast atrophy post-lactation is another example. In pathological conditions where the reduction in the number and size of cells mainly due to starvation atrophy. This is a good example for cachexia patient in cancer where there is depletion of both carbohydrates and fats and catabolism of proteins which leads to anemia. And second one is the ischemic atrophy. In this pathological condition where the nutrition supply, basically the atherosclerosis, which lead to the atrophy of the organs. Next is disuse atrophy. This is usually the post in the orthopedic patient where the in post-traumatic conditions, if the bandage is not being put properly, so it leads to the again deficiency of nutrition through blood supply. So again it will lead to atrophy of the muscles. Neuropathic atrophy, the best example is poliomyelitis or even carpal tunnel syndrome, where the nerves has been affected, which leads to the atrophy of the muscles. The final is the endocrine atrophy. Here the best is hypothyroidism or hypopituitarism, where there is atrophy of the thyroid or pituitary and other organs. So moving on to the mechanism of atrophy. The major mechanism of atrophy is whether it is increased of protein degradation or decreased protein synthesis. This decreased protein synthesis is basically due to the reduced metabolic activity, and the degradation of cellular proteins is because of the ubiquitin proteinase pathway. There is also increased autophagy. What is autophagy? It is the starving cells which eats their own cellular components for the survival. So the morphology of the atrophy is usually reduction in the cell organelles, chiefly the mitochondria, the myofilaments and the endoplasmic reticulum, which shows as a shrinkage in the size of the cell. This picture depicts the atrophy of the testis. Next cellular adaptation is hypertrophy. Hypertrophy is increased in the size of the cell. Okay, this again it is two types, physiological and pathological. The first cause being increased workload. In physiological, the best example is the muscle mass for the people who work out. So, and the pathological condition is the hypertrophy of the heart. So in both this condition, there is more synthesis of proteins which leads to the increased number of myofilaments, where there is also increase in the size of the force of contractibility. In physiological, the demand is more. In pathological, the demand is more because there is an underlying pathological causes, maybe an atherosclerosis or the decreased protein, energy to the organ. The other smooth muscle hypertrophy example for is stomach, where there is pyloric stenosis, the work overload. Next, intestine, muscle hypertrophy in Crohn's disease. Next, bladder hypertrophy due to prostatic hyperplasia. So the major mechanism underlying hypertrophy is increased production of cellular proteins. This is cellular proteins is increased because of the mechanical sensors, growth factors, basically the TGF or vasoactive agents, which signals two major pathways. In physiological conditions, it is AKT pathway, and in pathological condition, it is GPCR pathway, which also triggers the gene expression. So the major mechanism of hypertrophy is increased production of cellular proteins. Moving on to the third adaptation is hyperplasia. This is increased in the number of parenchymal cells. It is again divided into physiological hyperplasia and pathological hyperplasia. The physiological hyperplasia are hormonal hyperplasia or compensatory hyperplasia. So, the hormonal hyperplasia is increased in the functional space. The best example is lactation. So, where the breast enlarges during the lactational stage, where the hormones plays a major role. In compensatory hyperplasia, increase the tissue mass after damage or even partial resection. Example is hepatectomy. The second pathological hyperplasia, good example is excessive hormones and growth factors, basically endometrial hyperplasia or benign prostatic hyperplasia. In endometrial hyperplasia, the disturbance of estrogen or progesterone balances is disturbed, which leads to abnormal menstrual bleeding. In benign prostatic hyperplasia, there is excessive secretion of androgen. So the first three adaptations we have seen so far is atrophy, hypertrophy and hyperplasia. Now the major thing, next cellular adaptation is metaplasia. In this, there is change of one cell type to another. In this, till the first three, there is a control in the cell change. But here, there are no mutations or no cell divisions, but there is change of one cell type to the other. The major mechanism of metaplasia is different from other type of cell adaptations I've already told, but it does not result from change of phenotype of an already differentiated cell. It is a programming of a stem cell along a new differentiation of pathway from the external stimulus, basically from cytokines or growth factors or extracellular matrix component, which leads to the gene transcription. The best example for metaplasia is epithelial metaplasia is one. The two picture depicts the left one. It is the respiratory epithelium, where the tall columnar epithelium is changed to the squamous. This is because of the smokers. In smoking patient or in a chronic smoker, the epithelium is changed from the tall columnar to the squamous. The same way in Barrett's esophagus, the squamous epithelium is changed to the columnar epithelium. The changeover is actually good, but not always. The major disadvantage is, for example, the changeover of tall columnar cell to squamous in respiratory epithelium also decreases the secretion of mucus and the ciliary function is lost. So, if the stimulus persists for a longer time, it helps for the transformation into the malignancy. So, this is what we tell as the removal of the stimuli can persist a normal survival, or the persistence of the stimuli leads to the transformation of the malignancy. So the last is dysplasia. This is the disorderly maturation of cell in the epithelium, where there is alteration in the size, shape and organization of the cell, where the continuum of the mild to severe grade is present, and it is also a pre-malignant conditions. The major dictum of dysplasia is there will be increased number or layers of epithelial cells, disorderly arrangement of cells from basal layer to the surface layer, loss of basal polarity, that is nuclei away from the basement membrane, cellular and nuclear pleomorphism, increased nucleocytoplasmic ratio, nuclear hypochromasia and increased mitotic activity. So the picture depicts all the 7 major points, and the overall picture which depicts the 5 cellular adaptations being atrophy, where it is decreased in the cell size, hypertrophy, increased in the cell size, hyperplasia, increased in the number of cells, metaplasia, change of one cell type to the other, and dysplasia, the disorderly arrangement or maturation of cells, which is also known as pre-malignant conditions. So the final take-home message of today's topic of cellular adaptation is every cell adapts to an extent for the survival. So that is atrophy, hypertrophy and hyperplasia, where hypertrophy and hyperplasia are mostly interlinked. The next is metaplasia. It is a thought process of the survival or not. If the thought process is being removed and it is good, it leads to the survival. But dysplasia is a soil to move, fertile soil for moving on to the next level, that is cancer. So with this, I conclude the topic of cellular adaptations. Thank you.